2 milligrams in it, which one's more potent? 10 milligrams and 2 milliliters is much more potent because it's a higher concentration in the medication, right? Versus this. I have more of this and less of the bang, right? More of the fluid, less of the bang. This is like your bang. It's your bang for your buck, right? It's like going to a drug supplier, right? How much of that is powdered sugar, dude? How much of that is powdered sugar? How much is the real stuff? They're not going to give you a concentration. They're not going to be like, oh, it's 10 milligrams and 4 powdered sugar milliliters. They're not going to do that. They're just going to tell you, you know, it's not powdered sugar. That's crazy. But when we talk about medications being supplied to us pre-hospitally, we have to know what the concentration is because we need to be aware of the potential potency. All right? The efficiency of the medication is the ability for that medication to alter a cell response. How efficient is that medication? How long does that medication take to actually go into service and act? It's really important to know that. We want medications that act pretty rapidly pre-hospitally, right? You and I, we're not really in for the long haul. We want to fix it quick, right? Get in, get out, get done. That's all we want to do. Does it make any sense for us to have medications that have long-term actions but no immediate reaction in the pre-hospital setting?
No.
Yes. Yes, it does. Why?
Better for patient outcome?
Better for patient
Or the onset
outcome.
time takes so long?
Yeah, absolutely. Ondansetron, also known as Zofran, medication that we use to stop someone from being nauseous. It doesn't work immediately. In fact, the onset takes a good long time. At the same time, that 30-minute drive from initial patient contact to getting into the ER, that's long enough for that medication to go into effect. Did you do that patient any good? Mm-hmm. You think? We didn't reap the benefits. They still vomited all over me and my partner, but at the same time, it made them feel better.
20 minutes.
So it's important for you guys to know that. Oh, this is awesome. This dose response curve. This used to be the Bell effect, and they've actually made this a lot more simple. This is pretty cool. So the dose response curve. Okay, this illustrates the difference where the kind of the hand-in-hand nature goes between the relationship of the medication concentration and how effective it is. When I take a medication, I don't just arbitrarily mix it up in solution. There's a lot of information that goes into this and a lot of cause and effect that has to be studied to ensure that we have the most effective dose. So this is something that we don't necessarily know pre-hospitally, but something that the drug administration would know. They want to know what's the most efficient way for us to give this medication. I can tell you that you don't want to have 2 milligrams in 10 milliliters. It's not terribly effective. I can also tell you that having 10 milligrams in 2 milliliters is pretty effective. You don't need a bell curve or a graph to tell me that, right? Does that kind of make sense to you? You want more medication and less amount of volume, right? At the same time, there's a lot of science that goes into making this information available. Antagonist medications prevent cellular response to agonist chemicals. All that means is that it inhibits normal cell function. We talked about that. Does anyone not understand an antagonist? No one has questions about an antagonist, what an antagonist does.
Besides Narcan, what would another one be?
For an antagonist? Well, you guys tell me.
Thank you. There you go.
Okay. Okay. So when you have benzos pre-hospitally, that can be an antagonist. Another antagonist that we would use pre-hospitally would be epinephrine. Okay, because you're stopping a process. You're inhibiting that histamine response.
There's another opiate.
It could also be an agonist, though, depending on the dose that it's given. So that's where you get that 1 in 1,000 versus 1 in 10,000, and that goes back to that dosing administration. So when we get into epinephrine, we're going to talk a little bit about agonist dose versus antagonist dose. So there's 2 different doses to cause 2 different responses. All right. This is crazy. These competitive antagonists, they're temporary. These are temporary. These are quick fixes. And now let's talk a little bit about Narcan. Narcan is a temporary antagonist. It's a quick fix that does not last. That's why it drives everyone nuts when people get there, right? You have someone who's completely out, not breathing, vomit dripping out of the side of their mouth, you know, like the handprints on one side, they're blue in the face. You administer your Narcan, they pop up. Did you take any drugs? No. No, I didn't take any drugs. I don't want to go to the hospital. You can't make me. Well, and then you get into that weird game where the police is there. You want to go with me or do you want to go with him? Like, what do you want to do? And you get into this like strange little dance. Well, the issue is that it's a competitive antagonist. Okay? What that means is it's not going to last very long. They're going to get into the police car. They're going to go to the police, you know, wherever they're keeping them in the jail or whether they're keeping them in a holding cell. They're going to get there and it's going to wear off. And then what are they going to do? Stop breathing again. Then you got to start this whole dance over. Here I come with my organ. Okay, because it's not permanent. It's a temporary solution. Okay. Then you have non-competitive antagonist. It's a permanent bind. It's a permanent bind. Pre-hospitally, we don't have a lot of these medications where we're providing long-term permanent effects. A lot of these medications have to actually be given over a long period of time. There are these medications that have to have an accumulative effect where it builds on one another. So medications such as a lot of the depressive medications or antidepressant medications have a long-term effect where it has to become systemic. Those are examples of this. They're non-competitive. At the same time, they don't act immediately. It takes time to build it up. That's why you get patients who have been off their medications for a long period of time having some form of a mental crisis. It's because that prolonged effect has not taken place.
Is that like therapeutic aspirin? Would that be a long term?
That's a really good one. Or when I hear steroids up here, all that, yes, absolutely. So a steroid can have an immediate effect, but in smaller doses where you want to have it be long term, it's going to be given in much smaller dosing over a period of time for a therapeutic effect. And then you have things like aspirin, where you give smaller doses like 81 milligrams almost every single day or twice a day, depending on the patient, to build a long-term systemic effect. So good thinking. All right. Partial agonist chemicals. You tell me what that means. It's partial and it's agonist. Not 100% partial. Agonist, what is it doing?
Doesn't fully stimulate.
There you go. It's opening the door. That's all it's doing. It's opening the door. That's all it does. Does it actually stimulate a response?
Mm-mm.
Not necessarily. It can, but it's more just there to prime the pump, so to speak.
So would that be like insulin?
Yeah, that's a good one. So talk to me a little bit about insulin.
Allows glucose to enter the cell. It's the doorman.
It's doorman. Is that a sturgeon?
Yep.
Okay. Sometimes people say things and I'm like, that's a sturgeon. Okay. All right. Medications can alter cell function without interacting with receptors. This gets into a little funky thing. Medications have to be specifically engineered to do a specific thing. You don't necessarily have a medication that's just automatically engineered to go in the body and like, bam, do something. It has to get through certain processes. So when you have a medication like a cancer treatment medication, it has to be designed to do a couple different things in a row. Number one, it has to get through that cell-permeable membrane or non-permeable membrane. Number two, it has to bypass the body's natural processes. And it has to be engineered to target a very specific thing. Is it going to target a microorganism? Is it going to target a lipid or water or a toxic substance that's naturally occurring in the body? What does it target and how are we going to make it target that? So when we have medications that are specifically targeting a very specific area, we're talking medications for cancer treatment and we're talking medications for HIV. They're very, very highly designed. It's not something that you're just going to grab off the street and take over the counter from CVS. We're talking a lot more science behind it. Pre-hospitally, we don't have a huge amount of this. The one thing I will say that we have that we work pretty regularly with, not so much anymore, would be something that affects your lipids in your water, and that's going to be our diuretic.
HTC.
What pre-hospital diuretic do we use?
Hydrochloric.
Lasix. We don't really use it that much anymore, in all honesty. It's one of those things that's way down our line of protocol here in Pennsylvania. You do have to be aware of it. It depends on what your company's standing orders are, but yeah, absolutely. And the protocol does say to call command for it. But yeah, so that would be an example of that, where it's designed for a certain thing. It activates on the leukopenly in the liver. So it's really a situation, or the kidney.
Yeah.
I don't know what, did you guys see it? I had a mini stroke. You guys can get me to a stroke center, right? Like fast, I hope. Is there one nearby? Oh my God. Okay. All right. So another couple things that would be a designer thing would be antimicrobials. Very specific portions of the cell wall of the bacteria are going to be targeted. It's not necessarily that it's going to go in, it's going to wipe out the entire bacteria itself, but it's going to be very specific. Chelating agents are going to bind with heavy materials, and they're going to remove it from that system. So when you have someone who has heavy metal poisoning, you're going to have to go in and you're administering chelating agents. So that's more like when you get into hazmat treatment and hazmat awareness. You guys have all done your stuff, right? Like everyone's going to get that eventually, right? Hazmat, I hope, because I'm still missing a couple people's stuff. And I know I said the end of the year, but even so, just, you know, I'm going to forget. I know I'm going to forget. Oh. All right. But again, when you're talking about treating heavy metal poisoning pre-hospitally, really there's only a couple things we can give, and it's not going to actually be that alternative mechanism of drug interaction that we're targeting. We're actually getting to the point where we're starting to open the door so that people can give other medications to actually stimulate that agonist effect. Are you guys still with me?
Mm-hmm.
Are you sure?
Yeah.
I look like I'm losing some of you guys. I know we're almost at 9 o'clock. All right, diuretics create osmotic changes. That's when we talk about our Lasix. That's when we talk about changing the way that our body processes liquids and utilize liquids and excretes. Most important is excrete those liquids. Why would I want to get rid of someone's liquids? Don't we need liquid to live?
Change your blood pressure.
Change your blood pressure, absolutely. What else?
Change.
Edema. Ooh, pulmonary edema. There it was. Thank you. Pulmonary edema. If that fluid has nowhere else to go, it dumps into potential spaces. And one of the worst potential spaces it can dump into is the lungs. Why? Why is that like the worst ever potential space?
So you can't
Because
do
you can't breathe,
oxygen
right?
exchange.
Okay, all right, that's all. Yeah, we don't want to do that. Electrolyte-based medications. What do we have pre-hospitally that's electrolyte?
Normal saline solution?
Normal saline solution, yeah! Almost everyone gets electrolytes pre-hospitally, right? What about our calcium? Calcium electrolyte? Maybe. Depends. Okay, but definitely our sodium, right? Our sodium chloride that we give to everybody, normal saline solution. That was what I was talking about. All those slides that we just got done, that's what I was talking about when I said to you guys, I know you feel like you're lacking pathophysiology. No, you're not. As part of everything that we talk about, we're going to explain why we do it. So talk to me about agonists.
Stimulate.
We're stimulating an action. Talk to me about antagonists.
Preventing it.
We're stopping. We're doing what to our cell receptors? We're blocking them or we're cutting them off. Absolutely. Talk to me a little bit about the dosing. Talk to me a little bit about, what's that word we talk about where you meet that perfect dose?
Threshold.
Threshold. Excellent. We need to get to that threshold for that medication to work. Beautiful. Talk to me a little bit about what kind of a medication, what's the receptor site that albuterol stimulates?
Beta 2.
Beta 2, absolutely. When I'm talking about stimulating the heart, what am I talking about?
Beta 1.
When I talk about an inhibitory response, what medication do I carry pre-hospitally that would be an inhibitory response that would utilize an antagonist?
Narcan.
Narcan. Talk to me a little bit about another inhibitory response that I would use pre-hospitally. What other medication would I utilize for that? Epinephrine. And what does that inhibit? Histamine response. This is not hard stuff. You guys just have to go home and solidify it in your minds. But this is easy stuff, right? This is not terribly hard. I know you all are tired. I'm talking really fast. But it looks like, you guys are giving me the right answers. Positive, positive, positive. This is your first introduction to ALS? Oh my God, isn't it fun? What are you doing with medications? You're reaching into the body and you're making it happen. You are stimulating change. You are controlling somebody's body that's out of control. So we talked about why we give the medications. Let's talk about actually doing the medication. Factors that are definitely going to affect the response of the human body. We got to talk about the choice of medication. We have to be educated. Not everybody can get fentanyl. Maybe we have to use morphine. But wait a minute, if we're using morphine, morphine is a vasodilator. Can I necessarily give a vasodilator to a patient? Wait a minute, I have an ex-person, or wait, hold on. An ex-addict. Do I want to give that person morphine?
No.
Depends on the situation, right? We got to talk about the correct dose. Because remember, we have to give that direct dose that's going to stimulate and get over that threshold. So we have to know our dosing. Not saying that another dose isn't necessarily accurate, but we have to know what's the most accurate per protocol and what the insert in that medication actually discusses. We have to look at the route. How are we going to give that medication? Are we going to take our D50, pop off the top, and drink it? You better not. I'll find you. Find you. Okay? That's not what it was designed for. Why would I give something IV versus orally? What am I trying to bypass?
GI.
I got to get around my GI tract, right? We got to think about timing. Some medications have to be given slowly over a certain amount of time. You can't slam fentanyl. If you slam fentanyl, you get actually really nasty adverse reactions. Zofran is another thing that you can't slam. Zofran, also called aldosterone, if you slam it, that person is going to get vertigo and possibly some lung tissue paralysis. Nasty stuff. Manner of administration. The monitoring process. If I'm going to administer a medication, I have to know what could potentially happen. If I give morphine to a patient, what could happen to their blood pressure?
Drop.
It's going to absolutely drop. If I give nitroglycerin to a patient, what could happen to that blood pressure?
Drop.
It could drop. If I give epinephrine to a patient, what could happen?
Spike.
Everything spikes. If I give albuterol to a patient, what could potentially happen?
Spike.
Yeah, everything spikes. So you guys have to know what that cause and effect is. Those secondary adverse reactions that we a lot of times we forget about, and we really can't. So we have to know what kind of monitoring we need. We have to know about the age of the patient. We have to think about the percent of body fat, because it's going to take a lot more medication to dose me than someone who's half my size, right? Absolutely. If you have a 6'5", like big brawling dude who weighs maybe 300 pounds versus a tiny little eensy-weensy thing who's 5'2", 120 pounds, we got to think about how much medication we're going to administer. That's important. Percentage of body water, highest in newborns. Did you guys know that? Newborns have a high percentage of water? That's crazy.
That's why you're not supposed to feed them water, right?
Yeah, absolutely, because the body has so much water, it could become free radical, right? Because the body can't use it because we're at maximum saturation. Where does it dump? Lungs. Can't use it. There's always one creepy kid in the class, and I just found you. Okay, percentage of body proteins. Proteins change throughout our life. I don't have the same amount of proteins as my grandmother did. You know what I mean? We have to be cognizant of that. Age is a huge factor in what we do, not just size of the person. Let me tell you guys what. People hit puberty a lot faster than they ever have. Have you guys ever been called for an 11-year-old? And they open the door and they're like, hey, can I help you? And they're huge and you're like, hey, I'm here for the kid. No, it's me. Okay, am I going to dose them like a kid?
Nope.
It depends on the medication. Because it's not necessarily size. It may be their ability to process it on another level. You have to consider titration of medication for pediatric or elderly patients.
Where's titrate? Titrate.
Give me a second. Sometimes you have to titrate. I don't want you to jump to titration because you don't know how to do math. And I see it all the time. Oh, I titrated to effect. You're an idiot. There was no reason to titrate that medication to effect. You didn't have your calculator with you today. Okay? Titration is something that absolutely has to happen, and that is when you do it in an educated fashion. You say, listen, I have this woman who is 85 years old. They didn't need the entire dose of fentanyl. I only gave it until I saw the effect. That's appropriate titration. Having someone on a dopamine drip and saying, I titrated to effect, means you're a big jerk face. Particularly if you had a pump to do it for you. I will kick you right in your head. It's on camera. I'm going to kick you right in your freaking head. If you give dopamine and you don't do the math. Unacceptable. Unacceptable. Weight-based medication dosing. We're going to have so much fun with weight-based medication dosing. I can't even explain to you. I love med math. I can't do math. Listen, the kind of math I can do is like balance my checkbook and dose a patient, and that's it. I can't do math otherwise. But medication and dosing medication is really easy, and we're going to have an entire lab day dedicated to it, and the doc is coming in for it. We're going to have a lot of fun. I'm excited. It's going to be a lot of fun. So here's the thing. We always deal with the patient's weight in kilograms. Don't ever try to do math in pounds, because the rest of the world chose to adopt a metric system, and the United States decided not to. Why? I'm not really 100%, but you know. Anyway, so we have to make sure that we're always dealing in kilograms. So yes, every patient has to be converted in kilograms. Don't document pounds. It just means that you didn't do what you needed to do. Advantages. The amount of medication is proportional to the size of the patient when you're dealing with weight-based dosing. If you do a therapeutic dose, it's a little less goofy than just doing like, this was my dose. If you don't do milligrams per kilogram, there's definitely a risk with those medications that are administered just one dose. We, as paramedic students, love the medications that are given just one dose, like 2.5 and 3 ml, 2.5 milligrams and 3 milliliters. That's great. We can remember that. It gets a little difficult when you have medications that are administered per milligram, like Cardizam, 125 milligrams per kilogram, or micrograms per kilogram, rather. Ooh, that would be bad. So yeah, you have medications that are milligrams per kilogram, milliliters per kilogram. It's important to know those things. So here's the problem. In order to use weight-based dosing methods, we need to know how much a patient weighs. Part of our lab day is going to be looking at each other and trying to guess your weight. Don't get offended. Girls, don't get offended. It's okay. All right, it's okay. Because it's important for you guys to be able to eyeball it. Some
you know what?
Look at a couple people are like looking at me up and down. All right, but at the same time, you have to be really good at that. I don't even want to know. You have to kind of get in the
500 pounds
habit.
math.
Yeah, and also look at kids, guys. Look at kids and see if you can eyeball it. So here's the thing. When you do weight-based medication, pay attention for another 4 minutes. I have you for 4 minutes. Pay attention. Up here, 4 minutes. All right, when you do weight-based medication, it doesn't take into consideration all of the factors that are needed. It doesn't take into consideration distribution. Okay, if you have a 180-year-old woman, or yeah, 180-year-old, if you have a 180-pound woman who is sporting size triple FD cups, or F cups here, okay, is that really going to process the medication in her chest?
That's like all for a week.
Yeah. Okay, so, I mean, and these are things that we laugh about, but at the same time, that makes a difference. It really does make a difference. So things you have to think about. All right, we have to also think about our environment. If I'm coding somebody, okay, they're in cardiac arrest, I'm there, I'm trying to make a difference, I'm trying to save a life, and I'm taking care of somebody, and I'm doing it on the hot pavement, the medication is going to act differently than if I'm doing it in the middle of a snowdrift.